Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to begin a series on hypertension. Hypertension is a very common medical problem that affects millions and millions of people. In this country, roughly 62 million adults have hypertension. And when you have add to it the so-called pre-hypertension, which in my view does not particularly exist, but it's in the literature, that add up to 173 million people. Worldwide, 1.5 billion folks suffer from hypertension. Major problem. I'm going to outline that for you, but before I get to that, I want to again interest you in this book that I wrote a couple of months ago. It came out, The Art and Practice of Modern Clinical Medicine. If it has to do with up-to-date 21st century clinical medicine, you're likely to find the subject in this particular book. It has 136 chapters. It has 889 pages. It's a big book. It's about 10 pounds. You're likely to find it in your local public libraries and wherever books are sold. And you could also, I'm sure, get a few copies of the book in my office. Now, when 1992, I actually wrote my first book when I actually was learning how to write. You have to understand I'm self-taught, so nobody ever taught me how to write books. And 24 books later, I'm still writing books. This was my very first book, The Status of Health of Blacks in the United States of America, A Prescription for Improvement. Now, in this particular book, I introduced the subject as to what is the basis of hypertension. I came up with the idea that there has to be a gene that's located in the human kidney that is causing us to hold on to salt. And the reason for it, I've decided, was the fact that when one goes back to Mother Africa thousands and thousands of years ago, the exposure to the ambient environment there, it was so warm, it is still very warm, and folks were working in the field, and as you well know, water is at a premium in Africa. And God being God, and I'm sure I came up with the idea, there has to be a gene in the human kidney that is put there in order to hold on to salt, to hold on to water as much as possible, to prevent these people from collapsing and dying. And also, I want you to imagine, I know it's hard for me to imagine, the travel the people got from the slave that traveled. 12 million folks died during the travel from slavery to the so-called New World. The few that survived, clearly, they were put in the bottom of the ship and the whole, all kind of horrible condition these people were treated. And those that survived, they traveled without, with all the dehydrations and whatever, must have been able to hold on to sufficient salt to stay alive. And using my own experience as a youngster, often growing up in Haiti, I was put in a situation where to survive, I had to become a farmhand. And working in the farm since I was between 9 and a half, thereabout, 9 o'clock, 8 o'clock in the morning to 5, barefooted, bareback, in this incredible heat. I mean, the temperature in Haiti sometimes goes as high as 110. And then prior to that, you have to walk 3 hours on foot to get to the farm, and which means you have to get up somewhere around 5:30 in the morning, because you start at 8, and then you finish at 5. And you have to walk, after all this hard work, you have to walk back from the farms or wherever they're located. Sometimes it's 3 hours to get back. By the time you get back, that night is about 8 o'clock, thereabout. And people, of course, in Haiti goes to bed very early, 6:30, 7 o'clock, people are in bed already because they get up at 5 in the morning. So you sort of, from my own experience, I came up with the idea that how myself, having worked in that condition for almost 10 years, because I left the farm area when I was almost 19 years old. And so now that I was a physician, I'm thinking through how did I manage to survive this? Because this is brutal stuff. And it's so hot, you're walking barefooted, you're basically walking on heat. And then the heat is coming above as well. And you become so salty, you could take a piece of wood, which I frequently did, and scrub the sweat, which becomes salty, all over your, cake up as salt over your skin to scrape it up. So I said, you know, there has to be a gene. So I came up with the idea and I put those things forward. And sure enough, the powers to be went on and they had access to kidneys from Caucasian American, Japanese American, and African from either Kenya, I think it was. If I'm wrong, I'm sorry, from Kenya, it was so many years ago. And they actually grind up these kidney specimens and sorted out the gene, looking for this gene that I propose in this book and elsewhere. And sure enough, they came up with the gene. You can't make this up. I think it was Georgetown University, University of Virginia, and I think Emory University may have gotten involved in that research as well. And sure enough, they came up with the gene that's called G protein receptor kinase type 4. What was interesting about it is the fact that the gene was found in the kidneys of the white Americans, the kidneys of the Japanese American, and the kidneys of the African folks that they studied, and the same quality, the same quantity. Hence, the basis for essential hypertension. Heretofore, nobody knew what was the reason why people were hypertensive, okay? So, and this was published in the proceeding of the American Academy of Medicine, I think in 2001, something like that. So here it is, the gene is now discovered. That is completely revolutionized the entire way people approach the treatment of hypertension. Now the question is, are folks still listening? The JNC7, which is the committee that supervises hypertension in this country, have repeatedly issued a report regarding the need to use certain medication to treat high blood pressure. And this segment, it's going to be the first show is going to be the basics, so that you want to really understand the concept and you understand why hypertension is such a devastating disease and why it is, of all the diseases that we deal with in this country and across the world, that's the one that doctors least understood, and that's the one that they're treating the worst. Why? The reason is because to this moment, folks are, physicians in particular, and I'm not criticizing them, I'm explaining the facts the way it is, and I don't have monopoly to these facts, it's the truth, refuses to accept the fact that hypertension, essential hypertension, is the result of G protein receptor kinase type 4, which is located in the human kidney, regardless of the ethnicity of the human being, period. That being the case, then, one has to treat it with a medication that's going to remove the salt. Because if you don't remove the salt, a whole host of terrible things is going to happen. Even if one were to control the blood pressure using all sorts of other medications, the kidney will plateau right back up and the pressure will go right back up again. Consequently, you have 700,000 folks in this country who develop stroke every year, and many of them die. The disease is, of course, that's the result of hypertension, stroke, congestive heart attack, congestive heart failure, kidney failure, and the other diseases that can intertwine there, of course, is diabetes mellitus, obesity, high cholesterol, whatever, stress, whatever. This is a very serious disease, very serious disease. And worldwide, let me see, I have the stats there, 7.5 million people die from blood pressure every year. It's a big problem. But the folks refuse to listen. I know, because I see patients in my office every single week that have been seen by other highly competent, highly qualified physicians, and yet the treatment they were getting is completely inappropriate for blood pressure. You say, well, what is going on? Well, the resistance is it's you know, it is true, but the resistance is that it is difficult for people to accept the fact that the human race began in Africa. The G protein receptor kinase type 4 happens to be an African gene, had to be, because we started out in Africa, all human beings, to one degree or whatever. It doesn't matter what you think of yourself, what you may have been told or whatever. All of us are African on the inside, like it or not. Okay, so therefore then, folks refuse to accept that they have to be treated for blood pressure the same way black folks are being treated, and they don't want to deal with it. They cannot emotionally accept that fact. Consequently, they're using the wrong medication. And 93% or thereabout, folks who are hypertensive develop hypertension because of essential hypertension. That's right. 2% of folks can have what's called pheochromocytoma, which is a tumor, benign tumor that's developed on the adrenal gland that can cause someone to over-secrete adrenaline, which then can cause the pressure to go up. There's also maybe 1% thereabout of folks who develop what's called renovascular hypertension, where the arteries around the kidney become occluded with some increase in membrane. The increased membrane inside the vessel causes the vessel to become occluded, and then the blood pressure can go up. That's renovascular hypertension. So therefore, if one were to, I mean, if you look at the physiology, and I'm sure these folks are excellent physicians. They went to school. They had anatomy. They had physiology. They had pharmacology. If one go back and take a few steps back, realizing that you have less than 5% chance of the medulla of the adrenal gland secreting enough adrenaline to allow you to be blocked by a beta blocker to treat blood pressure. And guess what? One of the most common medications that are being prescribed to treat high blood pressure in this country, because that's where I practice, is a beta blocker. It makes absolutely zero sense. Beta blockers are fantastic medication for a whole host of other things. If you document that someone has pheochromocytoma, that's a different story. Then you must block the effect of the excess adrenaline that's being secreted by a beta blocker. Sure, if someone shows up in the emergency room with hypertensive crisis, the blood pressure is over 250, the systolic, diastolic is 150, they're about to bleed into the brain, you're going to give them labetalol intravenously to try to block the shock, as it were, the sympathetic system to transiently drop the pressure down, transiently drop the pressure down so that you save the patient's brain transiently, temporarily, and then you can go back and resume treatment with appropriate long-term medication. If the patient happens to have congestive heart failure, that's already existed, and they also happen to be hypertensive, sure, you're going to give a specific type of cardiac sensitive beta blocker, but that can't be the singular medication. It may not, it cannot be, okay? Furthermore, if the patient happens to be a black, Hispanic, an Asian, any non-Caucasian individual that are being treated for hypertension, it makes zero sense to give them an ACE inhibitor. It makes no sense because all black folks, all non-Caucasian folks have low renin. Okay, which brings me into the renin discussion. Again, this is the introduction show. There's a system in the body called renin, angiotensin, aldosterone system. Okay? Now, this particular system, we have a product that the kidney produces called renin. Very important. That's another aspect of genetics that you have to, as it relates to hypertension, that you have to understand. All black folks, all Hispanic folks, all Asian folks have low renin for a different reason. Asian folks have low renin because over the thousands and thousands of years, there happened to be a diet, to eat a diet that is very high in salt. That's a known fact. That's the culture. That's the taste. Well, the increased ingestion of salty food over the millennium suppresses the ability of the kidney to produce renin. So therefore, they have low renin on that basis. Okay? That's it. That's a genetic thing. Genetic is very penetrating and very adopting. So they have low renin on that basis. Black folks, on the other hand, has low renin because they had to maintain enough salt in the body, as I mentioned earlier, to remain alive as to not become dehydrated from the ambient environment that they were existing in Africa or in the Caribbean, like the condition that I existed working on the farm. That then, because they have to hold on to salt to stay alive, they suppress the ability of the kidney to produce renin. Hence, the gene that evolved causing black folks to have low renin. That's all. That's it. Nothing more fancy than that. You could do all the research you want. Those are the facts, okay? So, therefore, then, ACE inhibitors are excellent medications, but not for non-Caucasian folks. The only time or times non-Caucasian folks would have benefited from an ACE inhibitor if they have end-stage renal disease, during which time the renin is high. Everyone, regardless of the ethnicity, who have end-stage renal disease, the renin goes up. But guess what? Cannot use it. Cannot use it because one of the things you cannot do when you're treating somebody with end-stage renal disease, either the kidney is about to fail or fail completely on dialysis or whatever, is you are very afraid of the potassium going up. Well, if you put somebody on an ACE inhibitor, the potassium is going to go up. So because of that, ACE inhibitors are contraindicated in individuals who have end-stage disease, because that's the one lethal thing that can kill the patient acutely is elevated serum potassium that can cause cardiac arrhythmia and the heart can fail like that. So therefore, we clinicians know to back off, stay away from medication that can cause the potassium to go up, which is one of the side effects of ACE inhibitor. Okay? So therefore, we stay away from it. Then one of the most frequently prescribed medication for blood pressure for all individuals in this country happen to be ACE inhibitors because they are cheaper. All of them, at least chapter 1 in this book is on hypertension and all the different types of ACE inhibitors, which are very good medication, but in whom, all listed here. Okay? Then, of course, as the series evolves, when I get to treatment, you will understand that the cheapest, most effective medication to treat someone who doesn't have renal failure happens to be a thiazide diuretic. There are different types of diuretic. There's loop diuretic, the thiazide diuretic. The thiazide diuretic, my friend, costs $7 per month for 30 pills. Let me repeat that. $7 a month for 30 pills. And yet it is the most effective medication known to mankind, known to medicine, to treat blood pressure. And you could, well, how so? Well, I just told you. The basis for essential hypertension is salt retention. So therefore, you use the thiazide diuretic. Blood pressure is treated in a step ladder fashion. Unless the patient show up with a very, very high blood pressure. First of all, blood pressure is categorized in stage 1 through stage 4. The patient shows up to the office with stage 1 blood pressure, or stage 2 for that matter. You start them first on a thiazide diuretic. And you wait for a couple of weeks. If that's doing the job, that's all you need. If that's not sufficient, then you have to come up with a second medication. Now that's when the argument comes in. Which type of second medication or third medication you should give a patient who is hypertensive? The issue of starting patient with that's been resolved. Even though a whole lot of folks, doctors are not doing it, but it has been resolved. Because this happened to be the only disease in this country that I'm aware of that is in fact controlled by a committee is hypertension. So that issue has been resolved. Also, there was a major study done in Europe called the ASCOT study, which is the Anglo-Scandinavian study. So I'm going to do all the basics so that when I continue to talk, as the series continues, you will understand the concept. The ASCOT study, as you know, in England and in Scandinavia, another part of Europe, the government pays the bill, pay the bill for the treatment of individuals who are sick. So therefore, they control all the clinical information. So they decided to set up the ASCOT study, which is Anglo-Scandinavian study. That's what that stands for. They did that. They give a series of folks beta blockers only to treat their blood pressure. These were white folks, mostly. And they give another series of folks a calcium channel blocker, which is like Norvas and that kind of stuff, okay? Then they give another group of folks an ACE inhibitor. And then they give another group a combination of a calcium channel blocker plus a thiazide water pill. Guess what happened? The people who were taking the beta blocker, this is hundreds of thousands of people, the people who were taking the beta blocker alone failed tremendously, didn't work. The people who were taking the ACE inhibitor didn't work. Absolutely did nothing for these people. These people get hurt very badly. However, the people who were getting a calcium channel blocker in combination with the thiazide water pill, those are the folks who did the best. They suffer less from heart attack, they suffer less from congestive heart failure, and their blood pressure was very well controlled. So the ASCOT study is there, it's in the literature. You can't make this up. Something that is published in the major journal, in the literature, and still many folks are not listening because they were taught medicine using the Caucasian model. And I was taught using the Caucasian model. I went to Albert Einstein College of Medicine, the best medical school in the world. That's where I was taught the Caucasian model. I went to Montefiore Hospital training program where I trained one of the most fantastic, outstanding training program in the country. I was also taught the Caucasian model. Problem is, now people are realizing the powers to be, including the AMA, that model is faulty. Because it has to be faulty. Because you can't tell me you got 7.4 billion people in the world, okay, as we speak. 4 billion of them live in Asia. 1.2 billion of them live in Africa. That's 5.2 billion right there. And you're going to tell me they have completely different physiology from Caucasian folks, and you're going to use that model to teach your students, your intern and resident, to treat them. How is that going to work? It's not going to work. It's not going to work. So realizing that is a problem, now the AMA has already given out grants to 33 medical schools in this country who have accepted the grants to change the model. Yes, to change the model, change the way we're teaching students and change the way we're teaching interns and residents. Because the world is not just composed of Caucasians. Caucasians are by far the minority of the, I just finished telling you. I did not include the Caribbean and also the Americas, and that's 7.4 billion. I just mentioned the 4 billion from Asia and the 1.2 million in Africa, sub-Saharan Africa. We got a whole lot of black folks in the Americas, a whole lot of Latino folks. I didn't even include those. So you figure that out. So throughout the world, Caucasians are by far the minorities. So I say this to say that you can't let use that model because frankly and honestly, as someone who practices medicine 24/7, that is all I do, day and night. Either I'm writing it or I'm practicing it or I'm sleeping for a few hours. I'm here to tell you the only thing that's the same is the anatomy. That's all. As a matter of fact, the woman physiology is 100% different than the male physiology, and yet all the stuff that we're dumping into the market to treat these patients where the research were done using Caucasian male. Women were not included, regardless of the ethnicity, in those research. And then we're imposing our way of treating folks on these folks as well. That's wrong, period, like it or not. I couldn't care less what these people think of what I'm saying because it happened to be the truth because I read the literature. I receive at least 12 journals in my office per week, and I read all of them. And that's what's being said out there. And yet, folks are not listening. Every single week that I would receive a new patient in my office, which is something I do once in a while, it is shameful I will have a student in the office with me. And I have to explain these things because of all the absolute nonsense that these folks presented that were being done to them. Absolute nonsense. In some instances, disgraceful nonsense. And I have to, as somebody who represents the profession, because I'm an M.A.C.P, yes, I represent this proud profession, that I have to sit here and for the student coming from high-powered medical school to see this. Some of the stuff I will not even dare describe them to you on television. And we are not in some faraway jungle. We are here in the middle of the United States, and this nonsense is going on every day, 24/7, while they're wasting their time focusing on me to try to entrap me by sending people undercover to my office to diagnose, which 1,000,000,000% of the time I diagnose in 5 seconds, instead of concentrating on practicing quality medicine to help people, they're concentrating on me. And these people are crazy. I didn't do anything wrong when I was 7 years old trying to struggle without a mother and father. Why would I do it now that I have a nice suit, plenty of money in my pocket? These folks are insane. Why don't they pay attention to learn quality medicine? They can go to conferences all over the country. Some of them, frankly, should go back into training. They're that bad. So in any event, I will be talking to you about hypertension now that you have a little bit of an idea of the basis for the next several months, because it's going to take me a long time to detail to you this very complicated medical problem. Until I see you again, this is Dr. Alcena saying so long and bye-bye.